I'd like to welcome you all this evening to our community conversation, Ask the Expert Concussions. My name is Mike Carr. I'm the supervisor of Crawford County Sports Medicine at the Unionville Medical Center, also an athletic trainer and a physical therapist working within the sports medicine department. Each year, we see more and more issues involving concussions in our athletes that participate in sports within our schools. Our program services 10 high schools in the local community across all of Crawford County, as well as a few schools in Venango County. And the services that we provide within those schools include concussion management and all the care that's involved with taking an athlete from onset of a concussion all the way through a return to play in a safe, effective manner so that they are at least risk of further complications from concussions. Currently, concussions is a very hot topic within the sports world, going all the way from youth sports to the professional level. There are many concussions involved in the professional level that are resulting in litigation. The NFL currently has a huge settlement still outstanding in regards to care for some of the former players that have had issues with concussions and ongoing. Our sports medicine program really started to focus a lot on concussion management approximately 10 years ago, and those are some issues that we will discuss this evening as we go forward in our discussion with concussion and concussion management. Our focus this evening is really on the parental side of things, as well as some of the aspects of a concussion that you might see at home in son or daughter that might be having a concussion, some aspects of things that you can do for them at home, and then the care that we involve as we move forward towards a return to activity, as well as some preventative things as well. So, the staff from Crawford County Sports Medicine has worked very hard on this presentation. I'm very proud of the information they pulled together. I know they're looking forward to be able to present it as well. Just going to do a brief introduction. Bree is one of our athletic trainers. She's originally from the Concussion area and a graduate of Lock Haven University, and did some graduate work at California University of Pennsylvania. Whitney is a Sagertown graduate. Did her undergrad at Mercyhurst. Slippery Rock, and her graduate work at Mercyhurst, I'm sorry. Courtney is a Warren High School graduate who attended Pitt Bradford, and then also did her graduate work at Mercyhurst. Carrie is a Clearfield High School graduate, and went to Clarion University and Cal for graduate work. And Mandy is from Union City and did her undergraduate work at Mercyhurst and graduate work at Lock Haven. And we also have Dr. Teresa Wheeling with us tonight. She is a physiatrist with Orthopedic Associates of Meadville. And her expertise lies in the field of physiatry, deals with brain injuries all the way from concussions all the way to serious traumatic brain injuries. And as our program progresses, we are in the process of involving physician care with all of the concussions that we have come through our program. And her expertise in that has been very beneficial to us, and it's a very symbiotic relationship. So, without any further ado, I believe Whitney is starting today, and we'll get started with our informative session on concussions.
Tasked with just kind of giving a bit of an overview of what a concussion is, some very basic anatomy, and just again, just sort of just a general overview of some of the things my colleagues are going to talk about. So the first thing we want to talk about is what exactly a concussion is, because a lot of people, a lot of parents especially, that come in with maybe their oldest or even their youngest child, and it's the first concussion they've had in the family, they really don't even know kind of what they're dealing with. So it is a traumatic brain injury, and that occurs from a jolt, a bump, a blow to the head. Obviously, the head is what we're talking about, and specifically the brain. It does alter the way the brain normally functions, and what this creates is physical or neurologic symptoms that are kind of outside the norm for that individual. Previously described as getting your bell rung or a ding. Sometimes we hear sportscasters talk about it like this. A lot of times our coaches. We're really trying to get away from that wording of when we're describing head injuries, because it does kind of cheapen what a concussion actually is. For those of you who may watch sports, you'll hear the sportscasters say, "Oh, he just got his bell rung." And really, when we talk about it like that, it almost is saying he doesn't have a concussion, when really, a lot of times, we are dealing with a concussion. We want to take it seriously. We don't want to say it's just one of these things, when really all of those things are a concussion that we're dealing with. Concussions do trigger a metabolic change, not a physical change. And because of this, it's not detectable on X-ray, CT scan, MRI, or any other imaging technique. We are going to talk a little bit about how it's diagnosed, with obviously not having imaging to kind of look at it and say, yep, there it is, there's the concussion. And when you take your child, when one of our athletes or a child goes to the ER after a head injury, a lot of times they will do a routine CT scan, depending on kind of what they see when the child presents to the ER. And what they're looking for when they do this imaging is a more severe injury that really needs kind of rapid response care. So they really are looking more for a skull fracture, a brain bleed, or something that they need to be taken care of right away and taking seriously at that exact moment. So this seems a little bit silly, but a really good way to think about the brain when we're talking about it is a bowl full of jello. So again, it's sort of silly, but I did bring some jello. It is really a good visual. So if you think about the jello inside this bowl as a brain, it can move in all planes of motion. So when you shake your head, when you receive a blow to the head, anything like that, it can move. It can move front and back, side to side, diagonal. It can move all over the place. And it is obviously housed within the skull for protection, and that the skull is obviously a hard surface. It does continue to move within the skull once movement of the head and neck stops. So if this were someone's head and they received a blow or a bolt, when I stop, the jello continues to move for, a short period of time, but enough to maybe have some further injury happening. Set that down for a second. And another thing we want to talk about when we talk about this bowl full of jello and the brain in general is what's called a coup and a contra coup injury. So if we look at this picture, this is really just a very elementary kind of picture of the brain. Obviously kind of delineates different functions that different parts of the brain do. So when we talk about a coup and a contra coup injury, we are talking about when you sustain a blow to the head. So if I sustain a blow to the right side of my head, obviously there's going to be some initial injury to the right side of my head. But because of the force, there's potentially going to also be injury to the left side of my head. So that's what we're talking about with a coup contra coup injury. There's the initial injury to the side that is injured, and then there's the secondary injury potentially to the other side. Because again, the brain doesn't stop moving when the head stops moving, and just the force is going to obviously move your brain to one side or the other. So in looking at this picture, we may have an athlete that comes in and is maybe having some problem with behavior, problem solving, and maybe we know that they sustained a blow to the front of their head. What we often see at sports medicine is when we do our symptom inventory, we also see that these athletes are having maybe some problems with vision and balance, coordination. And you can see from this picture, again, it's very elementary, but you can see that those are controlled by different parts of the brain. So really when if you look at this and you know that your athlete sustained a blow to the front of the head, they're not necessarily just going to have problems with that area. They may have problems elsewhere. And again, this is because the brain, again, continues to move and can affect different areas. So one of the specific instances that we've seen about this is we had an athlete, a football player, who sustained a known blow to the back of his head. He knew and we knew that the blow occurred. He actually fell and injured the back of his head. He initially described seeing stars. Thankfully for the athletic trainer at the game, he wasn't unconscious or anything like that, so she was able to speak to him. And he said that he saw stars, so we can maybe see from this picture that he had some sort of vision issues, again from the initial injury to the back of his head. He did, after the play occurred, kind of pop up right away, which is a lot of times what our athletes, not just football players, are kind of taught to do, get up, continue with the play or with the game. So he popped up right away, and then he described an intense smell of burning rubber. So again, his may have had an issue with smell, which is again in this picture you can see is to the front of the brain. And then after that, he did start to become kind of belligerent and violent towards his athletic trainer. And this is a kid who really was very kind of well-mannered, liked his athletic trainer. So maybe again started having some trouble with behavior issues. So again, this kind of demonstrates the coup-contra-coup injury, where we know that he hit the back of his head, had some issues in that regard, but then again, when he kind of got up, he probably also sustained an injury to the front of his head through movement of the brain. All right. We're going to move on to sort of how a concussion occurs and some issues that we run into in this regard. So one of the things we want you guys to be able to take home is that the severity of the blow does not indicate the severity of the injury. We hear so often from parents, from coaches, he didn't get hard enough, hit hard enough, or she didn't get hit hard enough to get a concussion. And we know this to not be the case. Some very minor blows do correlate into a concussion when we do the evaluation. Evidence suggests that unanticipated hits, which cause increased head and neck movement, actually may yield some more severe injuries. And if you think about that, that actually makes a lot of sense. And again, it goes back to the brain continuing to move within the skull. So I'm going to come back to the jello for a second. And if I had a way to put this on some sort of arm that was kind of flexible and could move a lot, if this had an arm coming off of it, and this could move a lot. If we hit the arm and the arm was flexible and movable, this is obviously going to move a lot. So if we think about the brain that way, if you have a child that gets hit and they aren't anticipating it and the neck is moving quite a bit, then that would obviously correlate to the brain continuing to move. If this bowl was on something that was a bit more unyielding, if I had it on a baseball bat or something, and I hit the baseball bat, this is probably going to move a little bit, but not nearly as much as if it was on some sort of flexible surface. So again, if we think about our athletes or our students, if they can anticipate the hit and kind of tense their neck, their head isn't going to move as much. It's kind of those unanticipated hits or falls, things that they aren't seeing coming, that actually sometimes yield more severe injuries because their head and thus the brain do move so much more after that. Another thing we want you guys to take home is that force to the body, absent of direct blow to the head, may cause a concussion, and this is through a whiplash type mechanism. And we do see this quite a bit in sports medicine. Athletes come in and they say, I don't think I hit my head, or the parents who are watching the game say, I didn't really see him hit his head. But again, we do see this in sports medicine. A football player who gets tackled, on the body and kind of whips his head because he isn't anticipating the hit. I personally had a softball player last year who was playing outfield, and the ball was coming and she went to kind of dive forward, so her glove was out to catch the ball, and when she caught, her body hit the ground first. She caught the ball and then her head kind of whipped down, and I watched the play, her head didn't hit the ground, but she came out and it was very instantaneous that I could see that something was going on. And so it is that sort of whiplash motion. Also, a lot of times we get kids that get elbowed in the jaw. It happens a lot in basketball season. When we see that a lot, again, that would be kind of an unanticipated hit. Kids don't go up for a basket and think they're going to get hit with an elbow in the jaw. So we see some pretty severe concussions in that regard. And then a lot of times, or not a lot of times, thankfully, but unfortunately we do see kids that get into fist fights. And kids that unfortunately may get punched in the face or punched in the jaw, we do see some concussions from that as well. So we really want to get away from the fact that kids actually have to hit their head specifically on the ground, or a helmet-to-helmet hit. Concussions can obviously occur other ways as well. And then the last thing I have is sort of why we're talking about this today and why it's so important. Obviously, we know in sports medicine that symptoms keep kids out of sports. Not only do they not feel well enough, but it's not safe for them to return to sports when they're still symptomatic and when their concussion hasn't completely resolved and they haven't gone through a concussion management protocol. So we want to make sure that we can get them in here or to their physician, get them diagnosed, and kind of get them on the correct path. We don't want these symptoms to prolong any longer than they have to, because it can be pretty debilitating to kids. We have had some kids diagnosed with PostConcussion Syndrome, which kind of goes along with those prolonged symptoms. They can have prolonged headaches, long-term symptoms, and this is something that can happen, into adulthood. Personally, my husband has been diagnosed with PostConcussion Syndrome. He played high school and college football, and we didn't graduate that long ago, but the research has really improved since then, and he's had quite a few concussions that were either mismanaged, especially in his college years, and not necessarily just mismanaged, but kids are notorious for not reporting concussions, and he'll even tell you that he had quite a few that he didn't report. So we're obviously trying to avoid that as well. And then there is a lot of research going on right now about some long-term neurocognitive deficits, some Alzheimer and dementia-type syndromes that are occurring, and there is research going into that in regards to if there's a correlation between previous head injuries and then kind of long-term deficits that people are having. That's all I have. Courtney is up next.
As Whitney and Mike said, my name is Courtney, and I'll be going over some symptoms of a concussion, and also a little bit about what you can do as parents of a child that has sustained a concussion. Just some general information about the signs and symptoms. They do vary from person to person, so every child that sustains a concussion is going to have different symptoms, and they also may have different symptoms with subsequent concussions, so they're not always going to be the same. They also may not be immediately apparent and can be delayed by hours or even days after an injury, and they also can last for days, weeks, or even longer than that. One of the most important things about concussions is reporting symptoms. So you as parents need to be very aware of how your child is doing, and reporting symptoms is the most crucial for diagnosis. There's 4 different categories of symptoms that they group them into. There's physical symptoms, emotional symptoms, cognitive symptoms, and sleep changes that occur with concussions. Some of the most common physical symptoms include a headache, pressure in the head, nausea or vomiting, balance problems, dizziness, fatigue, blurred vision, sensitivity to light or noise, and sometimes they just don't feel right. Some emotional symptoms include irritability, sadness, they may be more emotional, or they may be nervous or anxious. Cognitive symptoms include difficulty concentrating or remembering, they may feel slowed down, or they may just feel like they're in a fog. They can't really describe how they're feeling. Sleep changes that may occur include drowsiness, sleeping less or more than usual, and trouble falling asleep. Some signs you can observe as parents or a guardian of a child that has sustained a concussion, and you're the first one that has come upon this child that has sustained an injury. They may appear dazed or stunned. They may be confused about what's going on, so they may not remember what they did in school the day before or what they did in school an hour ago after they sustain a concussion. They may forget an instruction that you give them. They may forget their class schedule in school or what kind of assignments they need to do for homework. They may move clumsily, answer questions slowly, and sometimes with concussions you do lose consciousness, even briefly, but not every concussion contains a loss of consciousness. They also may show mood, behavior, or personality changes. And that's kind of one of the biggest things that as parents or guardians you need to be aware of is the personality change, because you are the one that's around the child the most. So me as an athletic trainer isn't going to necessarily notice the personality or mood changes because I only see them when I'm treating them or doing an evaluation. I'm going to necessarily notice the personality or mood changes because I only see them when I'm treating them or doing an evaluation on them. But you as parents see them every day. You see them after school when they come home. So it's very important to notice how your child is doing and important to ask them how they're doing after they sustain an injury. Just a few examples of experiences that we may have come across at sports medicine. One is a 13-year-old female that may normally be bubbly and outgoing, and after sustaining a concussion, they are subdued, quiet, and withdrawn. So that's a big thing to recognize after someone sustains a concussion, and it's important to tell someone about what's going on with your child. It also may be the opposite too. You may have a normally subdued, quiet, and well-behaved individual, and after the concussion they are obnoxious or acting out. It kind of goes along with what Whitney was saying earlier, how she talked about the individual that got hit in the back of the head and became very obnoxious after getting hit. What can you as parents do? It's very important to watch for changes in how your child or teen is acting or feeling, and especially if symptoms are getting worse. You really need to be checking on your athlete constantly about their symptoms and how they're feeling. There are some symptom checklists that are available. You can either get them online or we as athletic trainers can provide them to you. We just need to let you guys know that you maintaining their symptoms should not be in place of seeking medical attention for your athlete. If your child or teen reports symptoms of a concussion or you notice that the symptoms are getting worse, you need to seek medical attention. So if your athlete becomes unresponsive, if they begin vomiting uncontrollably, you need to seek medical attention for that. Children and teens are among the most greater risk for a concussion. It's also very important to support your child throughout the concussion phase. So they may be very frustrated, sad, or even angry that they can't return to play after a concussion, or also that they may not be able to keep up with their schoolwork properly. They may feel isolated from their peers and social networks. So it's important to talk often with your child about how they're doing and offer your support and encouragement where it's needed. Are all concussions the same? Absolutely not. Concussions can share certain characteristics, but every concussion is unique to that particular individual and to the actual concussion. So if your child sustains one concussion and that they sustain a second concussion, that does not mean that the second concussion is going to show similar characteristics as their first concussion. Males and females can also show different symptoms, and age can play a role in the symptoms presented and how long the symptoms may last. A lot of people ask us how many symptoms we need to diagnose a concussion, and the answer is we only need one symptom. A blow to the head or body with one persisting symptom is enough for the diagnosis of a concussion. One of the most common misconceptions about the symptoms of a concussion is we'll have a parent or a coach come to us and say, well, my child got hit in the head, but they don't have a headache, so they don't have a concussion. That is absolutely not true. A headache is the most common symptom of a concussion, but that does not mean that every child that sustains a concussion will have a headache with their concussion.
Like Mike said, my name is Carrie. I'm going to talk a little bit about some modifications that you can do at home and school to help with your child. What should your athlete be doing after a concussion? Rest is the most important for recovery. Just like a ligament or a muscle strain, it's important to rest the body to allow for proper healing and prevent further injury. Make sure you're monitoring sleeping patterns, making sure your child is not sleeping too much and is receiving enough sleep throughout the night. Remember, physical and cognitive rest is the best intervention to avoid further injury and prolong recovery time. Some home modifications. If your child is diagnosed with a concussion, they should not only be taken out of sports, but discontinue all activities. Some examples are sled riding, skiing, snowboarding, backyard games, four-wheeling, and even hard labor chores like farming. Also, you may want to monitor usage of video games, television, reading, text messaging, and music. All of these activities can cause extra stress on the brain, which may cause symptoms to linger. In the past, Crawford County Sports Medicine has handled cases when symptoms in the child were lingering, and after speaking with the parents and child, we noticed that the child wasn't giving their brain proper rest due to the constantly being on their phones or playing video games for several hours, which could have been the contributing factor for their lingering symptoms. Some activity modifications, along with what to watch out at home, the athlete should be taken out of all sports and physical education classes. Also, for those children who are young enough to be in recess, it should be avoided to be in recess should avoid further activity while experiencing symptoms. Academic intervention. Even though your son or daughter is diagnosed with a concussion, in most situations will still need to attend their classes so they don't fall behind. Some academic interventions may consist of decreased workload in the class, allow extra time on projects, utilize tape recorders, smart pens, and utilize copies of teachers' notes. Adjust due dates, also remove or exempt students from tests or large projects, and have them focus on understanding the material. This picture basically breaks down and matches symptoms with some examples for interventions that may help your child get through their school day without falling behind or making symptoms worse. If your child is having a headache, blurred vision, or noise sensitivity, wearing sunglasses or putting them in a quiet room can help them. If your child is, having concentration problems, slowed for processing information, adjusting their due dates or allowing for extra time may help them. If your child is just mentally fatigued, allowing for rest breaks may help them. If you're noticing your child being more emotional, allowing the students to remove him or herself from the room may help them with going through with their concussion. In special circumstances, the Section 504 plan may be needed. It's a federal civil rights law under the Rehabilitation Act of 1973, which provides protection against discrimination for individuals with disabilities. Symptoms that last 3 or 4 weeks or longer, athletes may be required to fill out this Section 504 if the student is still having complications in the school setting. This Section 504 plan is typically not done through the athletic trainer, but may be filled out either through the school nurse or the guidance counselor.
As Mike introduced, I'm Mandy. I'm going to go through some statistics that go along with concussions. As most of us know, you see concussions through sports like football and basketball, but often they happen at home and things that might be missed in activities such as swimming, diving, surfing, go-karts, dirt bikes, four-wheelers, skateboards, scooters, sled riding, skiing, and even trampolines. The Center for Disease Control reports concussions have doubled in the past 10 years. In 2012, there were 3,800,000 reported concussions, which doubled since 2002. And ER visits for concussions ages 8 to 13 have doubled, while ages 14 to 19 have increased by 200%. And 4 to 5 million concussions are reported annually. They've doubled because research has increased. Education has increased for both professionals as well as coaches and parents. PIAA sanctioned coaches for grades 7 through 12 are now mandated to take concussion training before coaching in that season. And the awareness of signs and symptoms has doubled, which obviously increases the amount of concussions that are reported. 1 in 5 high school athletes will sustain a head injury during their athletic season, and 33% of high school athletes who have concussions do not involve a loss of consciousness, as I think Courtney stated earlier. High school football accounts for 47 of all sport concussions. 33% of them happen during practice. Soccer and ice hockey are close behind. Falling accounts for 40% of all concussions in all age groups, while motor vehicle accidents account for 14.3%. From 2006 to 2010, motor vehicles were the #1 cause of concussions in ages 15 to 24. The next few slides are just some sports specifics that I wanted to go through that were important to highlight. So I'll start with cycling. Ages 5 to 14 are seen in the ER for biking injuries more than any other sport. Wearing a helmet can decrease the risk of severe brain injury by 88%, and the proper fitting of that helmet can be just as important. 55% have reported not wearing a helmet. Without a helmet, as little as 2 feet drop can increase the risk of a concussion. And 50% of those 5 to 14-year-olds report that they own a helmet, but only 25% of them report wearing it. Cheerleading and gymnastics. 96% of reported concussions are during stunts and acrobatics. 90% of injuries were fall-related, and 36.5% of injuries were to the face or the head. And I think it's important to point out that the fall-related injuries might not be because of the girl that's on the top, but the girl that's on the bottom. And can she do a full body weight squat of her own? Can she physically lift enough weight to account for a girl that she's lifting many feet into the air? So that's something important to point out there, as well as only PIAA sanctioned cheer squads have to follow the safety rules. If you look at the picture on the left, that's a stunt that's not allowed in the PIAA sanctioned rules. And here at Sports Medicine, we only see a couple squads that are PIAA sanctioned, so we're actually seeing a lot of squads that don't have to follow those safety rules, which is probably where we see an increase in injuries to the head from those. Skiing and snowboarding. Head trauma accounts for 20% of all downhill injury. 70% of skiers or boarders wear helmets, which is a 5% increase since 2012. New Jersey is the only United States state that mandates all age groups wear a helmet. The Aspen resorts in Colorado mandate 12 years and younger wear a helmet. And it doesn't matter what skill level you are, whether you're professional or a 5-year-old, you should wear a helmet at all times. In soccer, 40% of concussions occur head-to-head. 10% occur head to object, which includes the ground, and 12.6% occur head to the ball. There have been multiple headgears developed, but no research shows any increase in benefiting against head injuries. As Whitney had pointed out, even if you had a headgear around your head, it's not going to stop your brain from moving inside your skull. And then some of the reasons why there might be an increase in concussions in kids younger than 14 are because they started playing organized sport at a younger age. Camps and club sports run all year round. Even if they're in a sport in the winter, they might still be playing a club sport on the side, so they're doubling up sports. And concussions occur in the non-traditional activities such as recess that are often overlooked at home.
Like Mike said, I'm Bree, and I'm going to talk to you just a little bit about how we at Crawford County Sports Medicine handle a concussion. We look at it kind of two different ways. We're going to do an on-field evaluation and a clinical evaluation. Speaking first to the on-field evaluation, we all kind of follow the mantra, when in doubt, sit them out. If we're even the least bit on the fence, the least bit nervous, rather be safe than sorry, have a seat buddy next to me until we get this sorted out. We do our absolute best to watch all of the athletes at all points of the game. Speaking, let's say specifically to football, we all know that hit where it's that big, massive hit that literally makes everybody in the crowd go, if I see that, I'm going to ask that athlete, are you okay? Might not be completely honest with me, so I am going to monitor them, continue to monitor them throughout the game. Are you sure you're okay? Are you feeling all right? Everything going okay? But like Whitney mentioned, it doesn't have to be that big hit. So I might not see the bottom of the pile where your son or daughter in their sport maybe gets kicked in the head. So that's where the importance of having your child, athlete, son, daughter, reporting their symptoms to us, to letting us know, hey Bree, kind of got kicked in the head and I don't feel right. They have to let us know that because I'm not going to be able to see the bottom of the pile, what goes on under there. So that's the on-field part of it. As far as the clinical evaluation, we feel at sports medicine we've always been just a little bit ahead of the curve with our concussion management. It's going to go through a thorough history. How did the injury happen? What were you doing? What exactly went on? A symptom checklist. We have, like Courtney mentioned, we go through about 22 symptoms and ask them to rate them. 6 being the worst that they are, 1 being not really having that symptom. Checking their cognitive abilities. Usually ask them to, I give them 3 words to remember. Ask them immediately if they can remember them. Go through a few other things. Ask those words again for kind of a delayed memory recall. And we have recently added some cranial nerve and upper quarter neurological screening, balance testing, and some pupil reactivity and convergence. I'm going to just demonstrate some of those just real quick for you. So maybe if you want to compare me. There are 12 cranial nerves. I'm not going to go through all of them. The first one would be asking me, can you blink for me? Making sure she can blink. Can you smile? Making sure the smile is equal. She's not droopy on one side. Asking, can you hear this? Can you hear this? And my favorite, can you stick your tongue out for me? Make sure the tongue comes out even, not off to the side, comes out straight. As far as an upper quarter screen, just briefly, maybe ask the athlete to shrug their shoulders. Try to resist here. Make biceps for me. Have you hold nice and tight there and try to pull them over. Pull over your heels. Arms out to the side. Again, resist up against me. Good. Fingers out. Hold your fingers out nice and tight there. Trying to squeeze them together on both. And then do the opposite, keep them in nice and tight, and trying to pull them apart. Just making sure that she's able to do the things that I'm asking. I don't see any major deficit there. As far as balance testing, do you feel comfortable on one foot? Have the athlete stand on one foot. Place your hands on your hips. First making sure she can get in the position, then have them close their eyes to test their balance then. So making sure she doesn't fall over. Good. When it talks about pupil reactivity, we go by what's Pearl. Pupils equal and reactive to light. So I have my handy pen light. Just look straight ahead there. Coming in, making sure the pupils react the way they're supposed to. Making sure one's not really lethargic or slower or bigger than the other one. And then as far as convergence testing, you stare at our pen light here, and then just follow the pen light. Have the athlete track the light. Make sure that she's able to do that. Make sure the eyes are going together. One's not doing something different from the other one. So, once diagnosed, what happens? Like Courtney and Whitney both said, it only takes one symptom to diagnose a concussion, and that's how they are diagnosed, is based on symptoms. CT scans aren't showing you if you have a concussion or not, and I wanted to make sure I mentioned that in the state of Pennsylvania, athletic trainers can actually diagnose a concussion. So, once that happens, we utilize a stepwise progression for full return to play once the athlete is symptom-free. Each step is going to build on the previous one, and the athlete must remain symptom-free throughout each process. So if their headaches come back, kind of put them on pause until their headaches, or symptoms, I shouldn't just say headaches, go away, and then continue through the progression. And then, due to new research and legislation, we've asked that Dr. Wheeling is now, like Mike said, going to be a part of our return to play process. Just want to touch briefly, we do utilize neurocognitive testing, namely the impact test. We have used this since 2005. I know in the last few years it's been kind of the buzzword even in the NFL. It's not a new thing. We've been doing it since 2005. And based on the importance of it and the information that it does provide to us, Mevo Medical Center has provided the subscriptions to the impact program that we use in our the 10 high schools that we cover. Important to note that the impact test that we currently have is actually designed for athletes kids age 11 plus. We've been told for many years that they're working on a pediatric version. We haven't seen that yet, so we do use it on kids age 11 plus, but it doesn't mean we can't manage the concussion without using impact, because it doesn't diagnose the concussion. It is a tool that we use to manage. Kind of food for thought, little statistic. From July 2011 to January 2014, we have administered 761 post-injury impact tests. So that's a large number. So,
Bree,
yes.
do you want to tell everybody about when baseline testing is done for impact testing? I think that's important.
Sure. We try to do baseline testing 3 times in a high school career in grades 7, 9, and 11. We do every other year to allow for brain development and growth. It's not a ton that goes, year to year, so we go every other year. And ideally, we do our baseline testing prior to them actually starting into any kind of organized sport, because we want to get the most accurate picture of the athlete. So we try to get them before they start in basketball practice, before a chance of injury occurs, and also before they're just tired and cranky and I just came from practice and I don't want to sit here and do a computer test. So 7, 9, and 11, prior to the start of their organized sports season, is when we do our baselines.
We discussed a lot of information this evening on concussions and what they are, the symptoms you're going to see, some modifications regarding how you can help your son or daughter that is concussed at home, some statistics showing the increase in the reporting as well as the prevalence of concussions. We wanted to finish with a little bit on prevention. It was touched on earlier, but essentially one of the easiest things there is to help prevent a concussion is to wear a helmet. As Mandy had mentioned, a lot of kids report having a helmet, they don't wear it. A lot of kids report, or the amount of decrease in the percentage of a concussion just with wearing a helmet was very dramatic. And so what we found is, as the concussion in the mainstream continues to be more and more, and people are maybe even starting to consider whether or not they're going to let their child play football, let their child play ice hockey, making those kinds of decisions based upon the fear that they may have of their child suffering a head injury, they then, on the other hand, will still let their son or daughter go home and ride a bike without their helmet on, or skateboard without their helmet on, or ski without a helmet on. So when you're looking across the picture of what we can do to help prevent that, the incidences of concussions are going up, and that is correct, mostly probably because of better reporting and research. But it only takes one incident, and that incident could happen in football, but could happen as you ride your bike. So by wearing a helmet when you're participating in these activities of bike riding, snowmobiling, scooters, ATV riding, contact sports of football, lacrosse, and ice hockey, inline skating, running the bases, playing baseball and softball, riding a horse. We see a tremendous number of concussions that occur in the wintertime due to sled riding accidents, snowboarding, skiing. We have a lot of times it's not necessarily a wreck. Sometimes it's just when they, slide off the board, and the ice can be very, very hard, and they'll smack their head on the ice. It doesn't even necessarily even have to involve an accident on a sled. It can just be a generalized dismount off a sled, and they can hit their head. And those things do happen. So wearing a helmet is very important, as well as making sure that helmet is a proper fit and then is maintained throughout the year. So if you have a son or daughter that's playing 6th grade football, 7th grade football, 11th grade football, they're fitted with that helmet at the beginning of the year. Now, do they have physical changes as the year goes on? They may lose or gain weight. The helmet itself may have parts of it that get adjusted, screws become loose. So not only needs to be fitted properly initially, but it needs to be managed throughout the year and maintained to make sure that it maintains a proper fit so that it's providing the protection that it's supposed to. Along with the helmet is also using the other protective gear that's provided. A mouthpiece. I don't know how many of you have seen, we see it every year. You go out to football camp and all the kids have trimmed off their mouthpiece so that there's only this much showing, it's not connected to their helmet, so that when they accidentally swallow it, when they have an injury, it's so much easier to get out when there's only a quarter of an inch sticking out instead of the whole thing. Or they'll take it and they'll trim off the backs so that it just covers their front teeth. Well, the mouthpiece, as we had mentioned earlier, when you take a shot through the jaw, that's a great way to really rattle your brain. If you've ever watched mixed martial arts or boxing, a lot of times that knockout punch, that bingo punch, is when that person gets hit right in the chin. And that's when they'll go, face first down. That's when they are out. And a lot of that happens through the chin. And so that gives a rattling of the brain. So when they make those modifications to their mouthpieces, that can be problematic. And as well, another piece of equipment that needs to be maintained. They chew on it all year long. It's something where they need to get a second mouthpiece halfway through the season. Proper techniques, tackling, blocking, all of those things are very important. As we had mentioned with the coaches now in the PIAA, they have to participate in online education. A lot of that involves the proper techniques of teaching those types of things, as well as then the recognition skills that they have afterwards. So definitely using the proper techniques when you're participating in the sport that you're involved with. Following the rules. One of the greatest rules of football is you don't lead with your head, the crown of your helmet. And then if you watch a game on Saturday during college football, Sunday during high school, or professional football, and then we'll see it on on our sidelines, our Friday night high school football games with kids leading with the top of their heads. And so not only are you creating a big risk for a concussion, but you're also setting yourself up for cervical injuries and much more issues in those regards. But again, that's what they see on TV. A lot of what we deal with are what some of our athletes see on TV. They see that Ben Roethlisberger came out of the game with a concussion and was back the next week. They see that some of the big hits from some of the safeties and cornerbacks come where they're leading with their head, and so those are some of the things that we have to battle with. But obviously follow the rules, especially those that pertain to safety. Practice good sportsmanship. Sometimes that's where you'll get an injury. Like we had mentioned earlier, somebody's a little bit off guard because the whistle blew, and then somebody gets hit. And so that's something where we instill that good sportsmanship with our athletes, then we're able to try to prevent some of that stuff. An athlete has completed the play, the whistle blows, and that's where it stops. Somebody then hits them after the whistle, they're unprepared for that hit, and then you can get that whiplash type effect and end up with a concussion. And then the Safety and Youth Sport Act, that was a General Assembly bill in Pennsylvania that was passed in 2012. And essentially that has laid the groundwork for a lot of the stuff that is getting pushed into the high school setting now that we've pretty much been following since 2005. It is the program that has now required the coaches to do concussion training online. It has set up a system that essentially they want a system in place that helps to diagnose, follow through concussions, which is something that we've been doing for quite some time now, in providing the ability to recognize that an injury has occurred, be able to assess it appropriately, and then manage that athlete from the onset of the concussion all the way back. They set up some guidelines for who can do concussion management. That bill is the one that has said that not everybody can just, even if you're a physician, if you don't have some additional training in concussion and concussion management, then you should not necessarily be the one that's releasing somebody back to participation. They want individuals that have further education in those areas so that we follow through with making sure that those kids go back safely. Because as you had seen throughout the information that we provided today, some of these things can be very long-term. And we see that every year. We see a kid or two that has a concussion that occurs early on, and it takes 1 to 2.5 months to get that athlete back. Variety of factors, not letting their brain rest like we discussed. Younger athletes. The younger athlete is certainly a little bit more potential to have longer problems. They have a developing brain. So if you take a 7th and 8th grade boy who's already maybe a little screwy to begin with because they're maturing and developing, and then you put a brain injury on top of that, then they can really be a longer terms in regards to trying to come out. And one of the big things that we see with concussions, as well as some of the other injuries that we see, is the social networking that is involved with that athlete in the sport that they participate in. They're a football player, they're a hockey player, they're a wrestler, soccer player, girls basketball, and their teammates depend on them. And those teammates' parents depend on, there's a whole line of things, and now you remove them from that, and then you suggest that they not play video games, not talk on their cell phone, not text. You're crashing this 16-year-old world down. So that supportive aspect of what you see and work with is very, very important to those athletes. One of the other things that I forgot to mention as far as prevention goes is making sure that the athlete is in good shape. We want to make sure that they have a good structure, as Whitney had mentioned with the bowl of jello. If you've got somebody's head on a little pixie stick compared to a baseball bat, you've got a much more secure structure. So if we, along with proper techniques with tackling and those kinds of things, we have the ability to make sure that we do good strength and conditioning. Make sure that if the person is not skeletally mature or have the strength enough to do the activity that they're doing, such as some of our younger athletes maybe heading a soccer ball, maybe that's something that needs to be looked at to make sure that it doesn't happen. So, prevention is challenging, and there's always going to be concussions, and it only takes that one event, and it can happen in a variety of manners. But a few safeguards can certainly help in that aspect, especially wearing a helmet when you're doing some of the things that when they're doing certain activities that you might not consider normally necessary. So, Dr. Williams, do you have anything to add or expand upon?
Oh goodness, that's like opening a can of worms. I don't think you want me to expand on a lot, but I could probably expand on one or two things and then maybe take some questions.
Absolutely.
That might be the easier way to do it. I think Mike really said it well about prevention, and maybe a point to drive home is a point that we all miss, maybe a myth or a fallacy that the common person thinks of, is that kids' concussions are milder and they recover quickly and they're not as severe as somebody who is older, and that is absolutely a fallacy. A concussion in a child or a teenager should be taken much more seriously than a concussion in an adult because of their developing brain. And it's the developing neurons, and the nerves are not completely covered with myelin that get injured, and they take a longer time to recover. So in the past, they would say, that's okay, he's 12, he'll be better tomorrow. That's absolutely wrong. They need more time, more attention, and more concern for recovery from that concussion. And then I think one of the things we haven't mentioned was the second impact syndrome. We're all talking about concussions and preventing them, and why are we paying so much attention to concussions? And the reason is to prevent that second concussion immediately after the first, because the second impact often causes death. And it's what you read in the newspaper. It's what you read about the football player who was out there and he didn't tell the trainers and the coaches that he had the first concussion and he got the second one. And the reason that happens is very metabolic more than anything. When we mention the fact that there is not structural damage, there really is not, that we can see by our tests at the current time. But is there structural damage? Absolutely. There is cellular damage. There is damage that takes place at the cellular level of the brain. And what happens when we have cellular damage? Think about an injury to the skin or a bruise. Now, I'm not saying the brain is bruised because that's a different injury, but if you have an injury to the skin, like a blister or a burn, hot water, and you get burned, and you look and you say, there's nothing there. And then all of a sudden, 10 minutes later, there's a blister. It's because there's a cellular reaction. We release vasoactive amines, and the cells are reacting to that injury. In concussion, very similar thing happens, and the cells become very fragile. And that's after that first concussion. After the second concussion, those fragile cells can bleed. And then that big structural bleed is what causes death. And so the importance in all of this is preventing death in our athletes. And nobody wants to think about that, but that is really what we're trying to do here. Every athlete, whether it's the soccer player, the motocross rider, the football player, it's really preventing that second concussion to keep them from dying. And then in the process, we've learned about the whole process of concussions and all the other effects, the side effects, the symptoms that we can deal with. And all of those things happen because of the cellular changes. And although we don't have any tests yet, there is lots of research. And we're going to very soon. There are biomarkers they are looking at, blood tests we can do that can take your child in the emergency room, and we can test for neurotransmitters. And has there been a release of this neurotransmitter that says, aha, their brain has been injured. And then they're trying to use that as a marker to say, they can't return to play until that comes back down to normal. So there certainly are things on the horizon to make this a little bit easier for everybody. And the question I get most from parents is, why do they have all these problems if there's nothing wrong? If their brain isn't damaged and we're not worried, why do they have all these problems? And it again goes back to an analogy I use for everybody to understand. It's certainly not scientific, but my analogy is with loss of electricity to our house. And I say you can have a big loss of electricity to the house, you can have a very quick brownout. And what happens to our appliances when we have quick loss of electricity? Some of them come back on with no problem at all. There's no flashing lights, there's no anything. That could be a very mild concussion. What happens when it's a little bit longer? It comes back on, we have flashing lights. Your brain is like that flashing light in the concussion. All those electrical connections haven't quite made it back yet. They're all not working on 100%, and the brain will present that disorganization and that attempt at reorganization by things like behavioral disorders, emotional disorders, intolerance to light, headaches, while it's trying to reorganize. And that's why the student, the athlete, needs a quiet environment. They can't have multiple things happen at the same time. They can't have music going on and somebody talking to them and trying to do video games, because it's too much stimulation for this brain that's trying to reorganize all these neurologic patterns. So it's why things need to be quiet, why they need to be dark, why they need to sleep more in order to let that brain reorganize. And severe traumatic brain injury is the extreme of that, where we have to do extreme repetition of motions to get those neurologic connections to work the way they used to. And so concussion is the mild end of that. So that's probably the areas that I would mention the most that I think kind of got skipped over. But otherwise, I think everybody did a fabulous job. I think you did a great job in explaining to everybody why this is such an important thing. What kind of questions could we answer for it?
So I've had multiple concussions, and 2 that were diagnosed. And I specifically remember 2 different trainers managing them for me. And the one was probably 15 years ago, and it was, well, say the word, I'll tell you 3 words, repeat them in a couple minutes, and then if you repeat them accurately, you're good to go. The other one was, I was out for a few days and managed and watched and observed. The prolonged side effects in each one were profoundly different. The second one had much longer side effects, and I had headaches for extended periods of time. But really, after the 72 hours of observation, they kind of let me go along my way, and I was back to playing sports. When should we really, at what point, as we're observing kids or our own children, do we say, okay, it's been a couple months, but you still aren't acting right? How do we really recognize that he's not just lazy, he's lethargic?
Excellent question. And initially, after the mild concussions, it really is that 72 hours to 7 days when most people recover. Post-concussive syndrome, which is the persistence of that constellation of symptoms, can last anywhere from 2 weeks to 6 months. Sometimes a little bit longer, but in that case, I hesitate to call it post-concussive syndrome as much as I think that people really had mild traumatic brain injury. as opposed to just post-concussive syndrome, because post-concussive symptoms do go away. Mild traumatic brain injury, you would have a permanent deficit. So for your own children, it's really watching them through those next couple weeks and couple months. And how do we let them back to activity? It really is about symptoms. I see quite a few kids not comfortable that they still have some of these symptoms. And sometimes I get the kid who, after I've had them 3 days, they're better. Sometimes it's 2 months or 3 months. And what we try to do is set up the environment for the healing brain, which is educate the parents, try to get sleep cycles on track, and look at other causes of symptoms. There can be other causes of symptoms that are not necessarily due to the concussion. Headaches can be from neck pain. Headaches can be from muscle issues. Headaches can be from visual issues. So what we try to do is then address the entire child. Make sure they don't have a visual cause. Make sure they don't have inner ear disturbance. And address everything and put them in the environment of repetitive physical therapy, good home environment. We try to stay away from medicines if we can. Sometimes I'll use medicines to try and get a sleep cycle back in sync and then take them away. But really, it's just setting up the environment for that healing brain. We can't make it happen.
So in prolonged situations, it'll be a consistent symptom. It won't be spotting of a variety of
That's
symptoms.
correct. The symptoms shouldn't change. The symptoms should be there, and they should either persist. Could they become more obvious because you didn't notice them right away, or because maybe somebody was a little more lethargic and had a flatter affect initially as they start to wake up? Will you see a little more emotional disturbance that you didn't see? A shorter temper, a shorter fuse, you might see those things. But it shouldn't change. We shouldn't go from somebody just having a headache to 3 weeks later, well, now I have a balance problem. It should all be there from the get-go.
And that would be something that what we're really trying to instill is that you notice as a parent is different in your child. Why are they have such a short fuse now? Well, 3 weeks ago, I guess they were in a car accident. Maybe there is still something going on. Something where that's what we're trying to really put the onus back into that home environment, to have that seen by the parent or guardian to say, oh, this is different from what is the normal for my child. Mm-hmm. And back to your initial comment about the 2 different ways of concussions now, the new, when you had, given 3 words and then let back to go in your first instance, our education now is, as Bree had mentioned, if you get your bell rung, if you get any symptomology at all from a concussion, you're done. Practice or game. Used to be, if you had some symptomology and it went away in 5 or 10 minutes, you were maybe allowed to go back out and play. You're done. And then the next day, we resolve it the next day, then we do a better evaluation. And if symptoms are no longer apparent and everything seems to be fine, then we can start a bit of a progressive return to play outside of maybe the full management program. And if there are still symptoms lingering, then they go into a different type of a setting. But that's where the big change has occurred, I guess, in my career as an athletic trainer. I think you guys would agree, is now it's, if you have some symptomology, you were out of that contest. And that comes from all of the concerns of the longer effects, symptoms not showing up right away. That can happen a lot of times where somebody will take a hit, maybe have just a little bit of an issue, but then they don't have the full onset of symptomology until the next day. And for some people, it maybe is a little bit unfair because you can get hit in the head and just have a headache and it go away. But the ramifications of making a mistake in that regard far outweigh the person missing that practice or game in our, well, even in a pro setting. You see some of these individuals that are out there now that have the long-term effects of brain injury, that could be from one hit or multiple hits. So.
And the other thing for your own children and observing them is that we do have the ability to put them through neuropsych testing to look at their cognitive abilities. Even if they've never had an impact test, a neuropsych test is a longer 4-hour test that really looks at everything. how they think, how they remember. Are they better with visual cues or auditory cues? And mostly because if they are having troubles and their cognitive function has declined, it gives us a method to help them rehabilitate. So we can say to the school, this student is not going to do good with scrolling information on a computer. This student needs to have a quiet room. He might do better if you tell him the information as opposed to making him read it. And maybe that has to persist for 6 months, but the neuropsychologist can really spell that out for a school and a parent and a child and not set them up for failure and not make them feel so overwhelmed, like, oh my God, what's going on? My life is falling apart. So I think we have that at our disposal that we didn't probably back when you had your concussion and probably 10 or 15 years ago.
Correct.
You know?
Frida, do you have additional comments?
I was, I think it's pretty standard practice that we try to tell the parents, they're going to ask for some ibuprofen or Tylenol and try to recommend that they don't do that, at least in the first 24 hours. Because if there is something else going on, the last thing we want to do is throw ibuprofen in there and cause a whole other mess of problems. But then it also lets all of those symptoms potentially manifest. It's not just, hey, I have the one symptom, but I went home and took ibuprofen right away, so the rest of it didn't come out. We try to hold them off on the medication so that we can kind of get an idea of everything that we're dealing with. Not just the headache or the balance problems, but then, my eyes hurt, it's loud in here, the noise bothers me. So I think that's something that we as the athletic trainers, it's pretty commonplace for us to say, try not to take anything at first so we can see everything that we're dealing with symptom-wise.
And there is some medical rationale between that too. If your child or your husband or whoever has a concussion and they go to the emergency room and the CAT scan is good, and they're a little off, and the ER doc says, oh, just have a concussion, you're okay, take them home and you can just watch them. Well, what do you watch for? What are you supposed to do? How do you know? And the most important thing is if they do have symptoms right then, is just give them Tylenol for the first 24 hours for any headaches or body aches. And the reason being that whole cellular mechanism again. There are some types of head injuries that people have a very loosened period and then they get worse because bleeding becomes delayed. Or if there is a mild bruise, say, on the brain that's not seen in the initial CAT scan if there's no bleeding, something like aspirin will make that bleeding happen, and so you don't want to take that. Ibuprofen does not cause bleeding, but ibuprofen causes a little thickening of the blood, so you can get a little bit of a blood clot. So Tylenol for the first 24 hours to make sure nothing neurologic is blossoming. And you'll know if something happens, it's a big change in mental status. People will become agitated or belligerent or loss of consciousness, more lethargic. And is it okay to sleep after a concussion? Absolutely, positively, yes. But the important thing is to be able to wake somebody up. So a child, an adult, anybody, yes, take them home from the emergency room, let them sleep. It's how their brain is going to recover. But every hour or two, you just have to make sure they can wake up, know where they are, and let them go back to sleep for that first 12-hour period if it was a fairly good hit on the head. And then after that, they can sleep to recover. And fatigue is probably one of the most frustrating symptoms of concussion because the brain is trying to recover and they want to sleep. It's okay. It's okay to nap as long as they don't screw up their day-night cycles, as long as they're not sleeping all day and awake all night. If they're doing that, you have to get them to sleep all night first before you let them nap. So those are sort of the medical things right after a concussion.
Are there any other questions? Where our program is going is kind of in association with Dr. Whelan said. We are looking to become full encompassing in regards to the therapy side of concussions, sleep issues with concussions, the vestibular balance issues, visual, all of that. And so that is where we are progressing with our program, along with the return to play, impact testing, the guidelines, and those type of activities as well. So I certainly want to thank my staff for the time that they put in into the information that they provided. I think you guys did a great job, and for Dr. Whelan being here, and then for all of you guys being here as well. So thank you for taking time out of your evening to come and listen to what we feel to be a very important topic currently occurring with our sports and our youth athletes. So thank you very much.
Just with regards to community conversations that are upcoming, on March the 24th, 2 weeks from today, Mary, one of the outpatient nutritionist at the hospital, is talking along with Dr. Gailey. She's on call, so hopefully she can come, about bone health. Again, we're looking at bone health across the ages. Dr. Gailey has commented that she's sometimes seeing early fractures in some of our youth, and she is questioning the nutritional status of bones because of pop consumption. So she and Mary are talking about bone health, so it's not just a lecture to be for me as a postmenopausal woman. So across the ages of bone health. And then next in April, we have Dr. Berkey, who is one of the licensed psychologists at the Mind Body, who's talking about one-way relationships, living and working with the self-absorbed, related to narcissism being a growing trend. And so she's going to help us all learn a little bit more about relationships, and if we do have a narcissistic person in our life, how to understand how they feel, think, and behave, and how we can cope with those changes. So again, a really important, relevant topic, and that's on April 14th. So we'll keep you all informed for those of you that have shared emails, but thank you all for coming tonight. Thank you all. An excellent presentation. I really appreciate it. Good job.